Welcome to Nephrology Notebook. In this lecture, we are going to take hyponatremia apart the way we actually use it at the bedside. First physiology, then diagnosis, then safe correction. Before we start, this video is for educational purposes only and is not individualized medical advice. Any patient case discussed is hypothetical and used only to illustrate clinical teaching points. Hyponatremia is often taught as a list of causes: heart failure, cirrhosis, SIAD, diuretics, adrenal insufficiency, primary polydipsia, beer potomania. But clinically, that list is not enough. The patient in front of you may be seizing, or asymptomatic, or on a thiazide, or malnourished, or suddenly producing liters of dilute urine after fluids. The goal today is to build a mental model. Sodium tells us about water relative to effective extracellular solute. Symptoms tell us urgency. Urine studies tell us what the kidney is doing. And the correction plan must anticipate physiology, not simply react to the next sodium value. One terminology point up front: AVP, arginine vasopressin, and ADH, antidiuretic hormone, are the same hormone. In this talk, you will hear both terms. Let's start with the core concept that prevents most mistakes. Sodium balance and water balance are related, but they are not the same thing. The key teaching point here is that total body sodium mainly determines extracellular fluid volume, while water balance determines the serum sodium concentration. A patient can have very low serum sodium and still not be sodium depleted. That is the first trap. Serum sodium is a concentration. It reflects water relative to effective extracellular osmoles, not simply the total amount of sodium in the body. In heart failure and cirrhosis, for example, total body sodium is often increased, but total body water is increased even more. The result is hyponatremia with edema. In primary polydipsia, total body sodium may be normal, but water intake overwhelms excretion. In SIAD, the problem is not a lack of sodium intake. The problem is persistent antidiuresis, meaning the kidney is retaining water when it should be excreting it. So before asking how do I give sodium, ask, why is there too much water relative to effective solute? That question takes us directly into the first teaching case. Here is the first teaching case. A 34-year-old man with schizophrenia presents with a generalized seizure after drinking 4 gallons of water to purify his blood. His serum sodium is 112 millimoles per liter. After stabilization, he has no edema and no clear signs of low effective arterial volume. Question: why is he seizing but not edematous? The answer is distribution. Pure water does not stay only in the plasma. It distributes across total body water. Roughly 2/3 goes intracellularly, and 1/3 stays extracellularly. Since only a small fraction of total body water is plasma, massive water ingestion can produce severe cerebral water movement without producing obvious peripheral edema. The neurologic danger is acute hypotonicity. Water enters brain cells, causing cerebral edema. That is why symptoms matter more than the number alone. This case also reminds us that AVP may be suppressed in pure water ingestion, unless nausea, stress, seizure activity, medications, or another stimulus turns it back on. To sort that out, we need to distinguish measured osmolality from tonicity. Measured osmolality and tonicity are related, but they are not identical. Total osmolality includes all measured particles. Urea and ethanol can raise measured osmolality, but they usually cross cell membranes easily. Because they do not sustain a water gradient across the cell membrane, they are often ineffective osmoles. Tonicity, or effective osmolality, is what determines water shifts into or out of brain cells. Sodium is the dominant effective extracellular osmole. Glucose also matters when it is high, because it stays extracellular enough to pull water out of cells. Mannitol and some exogenous osmoles can do the same. Question: if the serum sodium is low but the measured osmolality is high, is it always true hypotonic hyponatremia? No. Think hyperglycemia, mannitol, contrast, or pseudo-hyponatremia. But also remember the nuance. Urea can raise measured osmolality without protecting the brain from hypotonicity. Once we know tonicity is real, the next bedside concept is effective arterial blood volume. Effective arterial blood volume is not the same thing as total body fluid. It is the arterial circulation as perceived by the baroreceptors. In a normal system, cardiac output, vascular tone, and extracellular volume match the needs of the arterial tree. Baroreceptors stay quiet. In heart failure or cirrhosis, the body may be overloaded, but the arterial circulation is underfilled. The baroreceptors interpret that as low effective arterial blood volume. The response is non-osmotic AVP release plus RAS activation. The body retains water and sodium, but water retention predominates, so serum sodium falls. That is the paradox of hypervolemic hyponatremia. Total body sodium is increased, total body water is increased even more, and effective arterial blood volume is still perceived as low. Clinically, This is why a swollen patient can still have high A versus P. The body is prioritizing circulatory integrity over osmolality. That physiology sets up the diagnostic matrix. For a stable patient, hyponatremia workup should be paired and early: serum osmolality, urine osmolality, and urine sodium. But the slide also makes an emergency point. If the patient has seizures, coma, or severe neurologic symptoms, do not wait for urine studies before stabilizing. Severe symptoms require immediate hypertonic saline, while diagnostic samples are collected as soon as feasible. For everyone else, the matrix asks 3 questions. First, is hypotonicity real? That is serum osmolality. Second, is AVP active? That is urine osmolality. Remember, AVP and ADH are the same hormone. Third, what is the kidney sensing about effective arterial blood volume? That is urine sodium, interpreted with context. Do not rely on exam alone when the patient is stable. Volume exam is useful, but often wrong in hyponatremia. Urine data help us avoid treating SIAD like hypovolemia, or hypovolemia like SIAD. Now let's walk through the 3 gates. In the case, the serum osmolality is 265 milliosmoles per kilogram. Question: is the hypotonicity real? Yes. A low effective serum osmolality, typically below 275 milliosmoles per kilogram, confirms hypotonic hyponatremia. If the osmolality were normal, we would think about pseudohyponatremia from severe hyperlipidemia or hyperproteinemia, especially with older indirect laboratory methods. If the osmolality were high, we would think about glucose, mannitol, or other effective osmoles. Hyperglycemia requires a corrected sodium interpretation because water shifts out of cells and dilutes serum sodium. But here, the patient is truly hypotonic. That means the brain is exposed to low extracellular tonicity. This explains the neurologic risk. Once true hypotonic hyponatremia is established, the next question is whether the kidney is appropriately dumping water or inappropriately retaining it. The urine osmolality is 450 milliosmoles per kilogram. Question: is AVP active? Yes. A urine osmolality above 100 milliosmoles per kilogram tells us the urine is not maximally dilute. In hypotonic hyponatremia, that means there is an antidiuretic effect. If urine osmolality were below 100 milliosmoles per kilogram, the kidney would be doing what it should, excreting dilute urine. Then the problem would usually be overwhelming water intake, low solute intake, or both. But a urine osmolality of 450 means the kidney is holding water. The next step is to ask whether that AVP activity is appropriate. It may be appropriate if effective arterial blood volume is low, or it may be inappropriate, as in syndrome of inappropriate antidiuresis. Urine sodium helps separate those 2 patterns. Now the urine sodium is 55 millimoles per liter. Question: does this look like low effective arterial blood volume? Usually, no. When effective arterial blood volume is low, the kidney activates RAS and avidly retains sodium. Urine sodium often falls below 30 millimoles per liter, unless diuretics, kidney disease, adrenal insufficiency, bicarbonaturia, or recent fluids confound the picture. A urine sodium above 30 millimoles per liter suggests that RAS is not strongly activated. In the right context, that supports euvolemic physiology and raises SIAD, adrenal insufficiency, hypothyroidism, and drug effects. In this case, the pattern is true hypotonic hyponatremia, active AVP, and urine sodium 55. That supports SIAD physiology, likely from paroxetine, pneumonia, nausea, stress, or a combination, after excluding adrenal insufficiency, severe hypothyroidism, kidney failure, and a diuretic effect. The key phrase is supports. Urine sodium is not a diagnosis by itself. That brings us deeper into SIAD. SIAD stands for Syndrome of Inappropriate Antidiuresis. Many clinicians still say SIADH, Syndrome of Inappropriate Antidiuretic Hormone Secretion. But SIAD is more precise, because the problem is the antidiuretic effect, not always a measurable excess of hormone. Classic SIAD is mediated by A versus P, but rare nephrogenic forms exist where AVP can be low or undetectable because the kidney's V2 receptor is activated downstream. In those cases, the problem is still antidiuresis. The old Zerbe classification is useful because it reminds us that SIAD is heterogeneous. Some patients have unregulated AVP release. Some have a reset osmostat. Some have a basal leak. Some have nephrogenic receptor activation. The clinical message is practical. Do not order AVP levels to diagnose routine SIAD. Use the 3-gate approach. Exclude mimics, identify the trigger, and reassess as the clinical situation evolves. Another useful clue is uric acid. Uric acid can be a helpful supporting clue, especially when the history is messy. In hypovolemia, low effective arterial blood volume drives proximal tubular sodium and water reabsorption. Uric acid gets reabsorbed, along with that proximal flow. Serum uric acid is often high or normal. In SIAD, there is mild extracellular volume expansion. The proximal tubule reabsorbs less sodium and less uric acid. The result can be low serum uric acid and increased fractional excretion of uric acid. Question: can low uric acid diagnose SIAD by itself? No. Diet, kidney function, diuretics, uricosuric drugs, and volume status all matter. But serum uric acid below 4 mg per deciliter, or fractional excretion of uric acid above 12%, can support SIAD physiology, particularly if it normalizes after correction. Now we shift to a different failure mode. Not too much AVP, but too little solute. Hyponatremia is not primarily an AVP problem. It is a solute delivery problem. Here's the question. If AVP is suppressed and the urine is dilute, why can the patient still become profoundly hyponatremic? Because water excretion requires solute excretion. If the patient excretes only 60 milliosmoles of solute per day, and the urine is diluted to 60 milliosmoles per kilogram, the maximum urine volume is only about 1 liter per day. Any intake above that is retained. If daily solute excretion is 600 milliosmoles and the urine can dilute to 60, then 10 liters can be excreted. The kidney may be working normally, but it has no osmoles available to carry water out. The dangerous moment is treatment. Food, saline, protein, tube feeds, or urea can abruptly restore solute excretion and trigger a water diuresis. The sodium may autocorrect fast. That is why low solute hyponatremia requires anticipation, not reflexive saline. This slide turns the solute concept into a safety warning. Maximum free water excretion is determined by daily solute excretion, divided by the lowest achievable urine osmolality. In hyponatremia, solute intake may be only 200 milliosmoles per day. If the kidney dilutes to 50 milliosmoles per liter, maximum urine output is about 4 liters. If the patient drinks 6 liters, 2 liters are retained. Now the pitfall. 1 liter of normal saline contains about 308 milliosmoles of instant solute. That can suddenly increase the kidney's capacity to excrete water. The sodium may rise not because normal saline itself is magic, but because solute repletion releases the brake on water excretion. In severe low solute hyponatremia, avoid routine isotonic saline, unless there is a clear indication such as hemodynamic resuscitation. If solute is needed, monitor sodium and urine output closely, and be ready to use desmopressin and electrolyte-free water. That same attention to physiology helps explain thiazide hyponatremia. Thiazides cause hyponatremia because they impair dilution in the distal convoluted tubule. Unlike loop diuretics, thiazides act in the cortex and tend to preserve the medullary concentrating gradient. So the patient may still concentrate urine but cannot generate maximally dilute urine. Add lower glomerular filtration, older age, lower body mass, hypokalemia, low solute intake, high water intake, and other medications, and the risk rises. The mini case is a 62-year-old woman started on hydrochlorothiazide 2 weeks ago. Sodium is 118 millimoles per liter, urine osmolality is 350 milliosmoles per kilogram, and urine sodium is 45 millimoles per liter. That can look like SIAD. Timing matters. Thiazide-associated hyponatremia often occurs early, but it can appear later when intake, kidney function, or medications change. With diagnosis covered, we now turn to the most urgent management decision: symptoms and chronicity. This emergency case is a 45-year-old woman 2 days after hysterectomy who received abundant hypotonic fluids and is now actively seizing. Point-of-care sodium is 114 millimoles per liter. Question: do we wait for a formal laboratory sodium before treating? No. Confirm it as soon as possible, but severe neurologic symptoms dictate immediate treatment. Seizure, coma, and signs of herniation are hyponatremic emergencies. The hierarchy is symptoms first, then chronicity, then cause. Acute hyponatremia, under 48 hours, carries high risk of cerebral edema and relatively low risk of osmotic demyelination because the brain has not fully adapted. Chronic hyponatremia carries lower edema risk but higher demyelination risk during correction. When chronicity is uncertain and symptoms are severe, treat the emergency, but assume chronic risk for the correction ceiling after the initial rescue. The goal is not to normalize sodium. The goal is to relieve brain edema enough to stop the immediate neurologic threat. That brings us to bolus hypertonic saline. Rapid intermittent bolus therapy gives 3% saline in discrete doses, then reassesses. Common institutional approaches include 100 milliliters over 10 minutes, or 150 milliliters over 20 minutes, repeated up to 2 additional times for severe symptoms. The target is an initial rise of about 4 to 6 millimoles per liter, not a normal sodium. The SALSA trial compared rapid intermittent bolus with slow continuous infusion in symptomatic hyponatremia. It supported bolus therapy as guideline concordant and operationally simpler, with no statistically significant reduction in overcorrection compared with continuous infusion. So the evidence supports bolus use, but it does not eliminate the need for monitoring. The practical advantage is control. You give a dose, check symptoms, check sodium, and decide whether another dose is needed. The next slide explains why a small rise can be enough. After 2 150 milliliter boluses of 3% saline, the seizure stops. Repeat sodium is 119 millimoles per liter. That is a 5 millimole per liter rise. Question: should we keep pushing 3% saline because the sodium is still low? Usually, no. Once severe symptoms improve after a rise of about 4 to 6 millimoles per liter, the rescue phase is over. The management goal changes from rapid symptom relief to controlled correction. Why does 5 matter? A small rise in extracellular tonicity can pull enough water out of swollen brain cells to reduce cerebral edema and improve severe symptoms. You do not need to normalize sodium to protect the brain acutely. At this point, ongoing therapy depends on cause, sodium trajectory, urine output, and osmotic demyelination risk. In chronic or uncertain duration, the rest of the day's correction budget is limited. Now let's switch from emergency care to chronic SIAD. The chronic SIAD vignette is a 70-year-old man with small cell lung cancer, sodium 124 millimoles per liter, asymptomatic, placed on a 1-liter fluid restriction. 48 hours later, sodium is 123. Fluid restriction failed. Question: can we predict failure at the bedside? One useful tool is the urine to plasma electrolyte ratio, urine sodium plus urine potassium, divided by serum sodium. If that ratio is above 1, the urine electrolyte concentration is higher than plasma. The kidney is excreting fluid that is relatively electrolyte-rich, meaning the retained water is effectively electrolyte-free. Fluid restriction is less likely to work unless intake is extremely low or urine composition changes. It is not perfect, but it is clinically helpful. A high ratio tells you that the kidney is not giving you much water clearance to work with. That sets up the treatment hierarchy. Chronic SIAD treatment should be stepwise and monitored. First, fluid restriction is reasonable when the urine to plasma electrolyte ratio is favorable and symptoms are not severe, but it often fails, and adherence is difficult. Second, increase solute. Oral urea is a useful option because it increases osmotic water excretion. It can work when fluid restriction fails, though tolerability, nausea, access, and monitoring matter. Sodium chloride plus a loop diuretic is another strategy, but blood pressure, edema, and volume status must be considered. Third, selected patients may need Vaptans. These increase electrolyte-free water clearance by blocking the V2 receptor, but they can cause brisk aquaresis and rapid correction. The major principle is not pick your favorite SIAD drug. It is match therapy to urine physiology, patient risk, and monitoring capacity. That caution becomes especially important with Vaptans. Vaptans block the V2 receptor in the collecting duct. That prevents aquaporin 2 insertion and promotes aquaresis, meaning water excretion without equivalent electrolyte loss. The benefit is obvious. They can raise sodium effectively in selected euvolemic or hypervolemic hyponatremia when first-line strategies fail. The risks are equally important. The response can be unpredictable. Overcorrection can occur. They are not for urgent neurologic rescue. They are contraindicated in hypovolemic hyponatremia. Tolvaptan has labeling constraints, including hospital initiation or reinitiation for hyponatremia, close sodium monitoring, avoidance with hypertonic saline, and liver injury precautions. So Vaptans are not casual outpatient salt pills with a different name. They are aquaretic drugs that require a diagnosis, a monitoring plan, and a reason. Now we move to the case every nephrologist worries about: severe chronic hyponatremia with high osmotic demyelination risk. This teaching case is a 40-year-old woman with severe chronic alcoholism, body mass index 16, found down and responsive only to pain. Sodium is 104 millimoles per liter. Potassium is 2.8 millimoles per liter. This is high risk from multiple angles: initial sodium below 105, malnutrition, alcohol use disorder, hypokalemia, and possible liver disease. Question: why does potassium matter in a sodium correction budget? Because potassium repletion can raise serum sodium. Potassium enters cells, and sodium and hydrogen shift out. Also, effective intracellular solute changes alter water distribution. Clinically, aggressive potassium replacement counts toward correction. In chronic hyponatremia, brain cells survive by losing electrolytes and organic osmolytes. If extracellular tonicity rises too quickly, the adapted brain cannot recapture osmoles fast enough. Oligodendrocyte injury and osmotic demyelination can follow, often delayed after apparent initial improvement. This is where the sodium went up nicely can become dangerous. The ceiling is not a target. Correction limits vary somewhat by guideline, but the modern clinical approach is conservative, especially in high-risk chronic hyponatremia. For lower-risk patients, many guidelines advise avoiding correction beyond about 10 millimoles per liter in the first 24 hours, and about 8 millimoles per liter per day thereafter. Some expert groups allow 10 to 12 in selected lower-risk patients, but that is a ceiling, not a goal. For high-risk patients, a practical approach is to target 4 to 6 millimoles per liter per day and avoid exceeding 8 millimoles per liter in any 24-hour period. High-risk features include initial sodium at or below 105 millimoles per liter, alcohol use disorder, malnutrition, hypokalemia, liver disease, and other factors that increase demyelination risk. The teaching point is simple. After initial rescue, slower is usually safer. The next problem is that the body may correct faster than you ordered. The case now receives 1 liter of normal saline for hypotension. 4 hours later, urine output spikes to 800 milliliters per hour, and sodium rises from 104 to 111 millimoles per liter. Question: did the saline itself account for the whole correction? Usually, no. The bigger mechanism is reversal of non-osmotic A versus P. The saline restored effective arterial blood volume. The baroreceptor stimulus turned off. The kidney suddenly began excreting retained electrolyte-free water. That is autocorrection. It is common in hypovolemic hyponatremia, low solute states after feeding, adrenal insufficiency after steroids, and thiazide cases after stopping the drug. This is why high-risk patients need frequent sodium checks, often every 2 to 4 hours early, plus close urine output monitoring. Sudden dilute polyuria is not reassuring. It is the alarm bell. One way to prevent this is the proactive desmopressin clamp. A proactive desmopressin clamp means we intentionally control the kidney's water excretion instead of waiting for AVP to turn off unpredictably. In selected high-risk patients, desmopressin can be given, commonly 1 to 2 micrograms intravenously or subcutaneously every 6 to 8 hours, with strict fluid control and frequent sodium checks. Hypertonic saline is then used in carefully titrated amounts to raise sodium at the desired rate. This approach is most useful when spontaneous aquaresis is likely and dangerous. Severe chronic hyponatremia, sodium near 105, alcoholism, malnutrition, hypokalemia, low solute state, hypovolemia after reversal, or emerging high urine output. The limitation is evidence. The clamp is a useful expert strategy supported by physiology and observational experience, but comparative outcome data remain limited. It also does not guarantee safety. Overcorrection can still occur if fluid inputs, urine output, or sodium monitoring are not controlled. If overcorrection has already happened, the strategy becomes rescue. In the case, sodium has already risen 7 millimoles per liter in 4 hours. For a high-risk chronic patient, that is too fast. Question: what is the rescue sequence? First, stop ongoing saline or other drivers of correction if clinically possible. Second, give desmopressin to shut down the aquaresis. A common dose is 2 micrograms intravenously, adjusted to local protocol and clinical context. Third, consider electrolyte-free water, usually dextrose 5% in water, to re-lower serum sodium below the safety ceiling. The dose is individualized to sodium, total body water, urine output, and the desired target, with repeat sodium checks every 2 to 4 hours or more frequently if unstable. The key concept is that re-lowering is not a failure. It is risk management. In high-risk chronic hyponatremia, promptly stopping overcorrection and re-lowering may reduce osmotic demyelination risk. This same electrolyte-free water logic also explains hypernatremia. Why include hypernatremia in a hyponatremia lecture? Because the same equation keeps appearing. Electrolyte-free water clearance. In hypernatremia, the problem is water deficit relative to exchangeable sodium plus potassium. The patient may be hypovolemic, euvolemic, or hypervolemic, depending on whether water loss, sodium gain, osmotic diuresis, diabetes insipidus, insensible loss, or inadequate intake is dominant. The urine electrolyte-free water clearance formula asks whether the kidney is losing or retaining electrolyte-free water. A positive value means ongoing water loss. A negative value means retention. Clinically, this helps move beyond static water deficit calculations. If the patient continues to lose electrolyte-free water in the urine, replacing only the initial deficit will undertreat the problem. The slide also notes emerging SALSA-2 hypernatremia data. The teaching point should remain cautious. Do not frame early signals as definitive superiority. Now we can unify hyponatremia and hypernatremia into one dysnatremia blueprint. This is the practical framework. First, measure correctly. Serum osmolality, urine osmolality, and urine sodium for hyponatremia, with urine electrolytes and urine output when water clearance matters. Second, classify physiology. Is the patient hypovolemic, euvolemic, or hypervolemic? Is the process acute or chronic? Is AVP active or suppressed? Third, set the target. Severity dictates speed. Chronicity dictates the ceiling. Fourth, intervene. Acute severe symptoms get hypertonic saline. Chronic SIAD starts with fluid restriction when favorable, then solute strategies, then selected aquaretic therapy. Autocorrection risk may require desmopressin. The take-home line is worth repeating. Sodium is a volume problem, but hyponatremia is a water problem. In shock or seizures, stabilize first. When stable, do not rely on exam alone. Get paired studies early and interpret later data in context. Let's close with the clinical pearls. The first pearl is to prioritize symptoms. Seizures, coma, and impending herniation require immediate 3% saline. The initial goal is a 4 to 6 millimole per liter rise, not normalization. Second, use lab clues to support, not assume. Low uric acid and high urine sodium can support SIAD, but you still must confirm hypotonicity and exclude adrenal insufficiency, severe hypothyroidism, kidney failure, and diuretic effect. Third, respect solute load. In low solute hyponatremia, saline, food, protein, tube feeds, or urea can trigger brisk water excretion and rapid correction. Monitor urine output and sodium closely. Fourth, consider a proactive desmopressin clamp when the risk of overcorrection is high. Sodium around 105, alcoholism, malnutrition, severe hypokalemia, liver disease, low solute state, hypovolemia after reversal, or emerging aquaresis. The final teaching point is that nephrology is not just math. It is the anticipation of physiological response. If this lecture was useful, subscribe to Nephrology Notebook and share it with a colleague who manages sodium at the bedside. As always, this discussion is educational and should not replace individualized clinical judgment or medical advice.